So we're talking about chapter 25. This is management of patients with heart failure. So this chapter 25 is all about heart failure, and that's what we'll be discussing. So, what is heart failure? In general, heart failure is just a clinical syndrome, basically where cardiac function is impaired. So, the mainly when someone's talking about heart failure, talking about the heart is lacking in its ability to pump effectively from the ventricles. So basically, the ventricles either have a problem with filling or ejecting the blood out, or both. Um, Sometimes this generally is referred to as CHF, congestive heart failure. But that's kind of a general term. You can say heart failure, you can say CHF. It's going to be acute or chronic. There can be acute episodes of heart failure, but most of the time it's a chronic development. And technically, heart failure is either going to be right or left, or technically speaking, it's going to be systolic or diastolic failure. These are some classifications. The next couple slides, these are not necessarily need to know. Basically, you can always talk about heart failures classified mostly based on how much the heart failing limits physical activity is a lot of where the classifications come from. They're a combination usually of how bad the heart failure is based on activity tolerance and how much blood the ventricle is actually pumping. So this talks about a bunch of different classifications. I don't think that's need to know information for you guys by any stretch of the means. Again, the problem with heart failure in general is going to be relatively the same. It's going to be heart failure is going to cause a deficiency in cardiac output, whether the cause of heart failure or the symptoms. It's always going to, heart failure means that the heart does not pump effectively. Therefore, there's going to be a problem with cardiac output. So, what causes heart failure? Myocardial infarction is a big one, and heart attack will damage myocardium, and then that will cause scar tissue development, and that will lead to the heart not pumping effectively. That goes hand in hand with CAD. Valve disorders where the valves are stenosed or regurgitating, insufficient valve function will mess with it. Infections, myocarditis, endocarditis, pericarditis, any of the infections could affect the heart. Arrhythmia development can wear the heart out as well. Uncontrolled chronic high blood pressure, some thyroid disorders based on how they affect heart rate. Pregnancy can be really tough on the heart, and even septic, especially septic shock, sepsis that prolongs the whole body shock is also potential for heart failure. So diastolic versus systolic, these aren't too big of a difference to know. They can kind of happen simultaneously sometimes in a way, but systolic basically is talking about weakened heart muscle. The heart muscle is, so when someone's systolic, the heart muscles become thin and weak, and the pumping effect is very bad. Diastolic basically says the heart has become stiff and thickened and hardened, where the muscle doesn't want to pump effectively. This limits mainly the filling and the ability of contraction. So diastolic heart failure, both are limiting. There's a key thing that's used to kind of talk about heart failure called ejection fraction, also known as EF. Ejection fraction is basically an indicator for the degree or classification of the heart failure. Normal ejection fraction is 55 to 65%. Ejection fraction is basically a percentage of blood ejected from the left ventricle during each heartbeat. So again, ejection fraction, EF, is a percentage of blood ejected from the left ventricle during a heartbeat. Normal is 55 to 65%. They get this kind of number by basically seeing how much blood fills and then how much blood gets ejected with each beat, or each round through the ventricle. Usually in diastolic heart failure, the EF can be normal. You'd be able to identify ejection fraction by a trained echo tech who's trained in cardiac ultrasounds and echocardiograms. Those will be the best way to determine heart failure and monitor its progression, is cardiac ultrasounds, also known as an echocardiogram. So the big difference for you guys to hone in on, the need to know here, the real big stuff is, what's the difference in manifestations for a patient that's suffering from left-sided heart failure versus right-sided heart failure? The best way to think about this is plumbing, guys. Like, think of plumbing, right? Your toilet backs up. that's going to back up into the bathroom. The water will flow up through the toilet and end up on the floor, and that's bad news. So with heart failure, to understand the manifestations, what it looks like in a patient, think about where did that blood just come from? It's like backflowing to where it came from, and that's where the symptoms will start. So left-sided heart failure is related to the lungs, because think about the left side of the heart. The blood that's coming to the left side's job is to pump it to the whole body. But where that blood just come from? It just came back from getting its gas exchange from the lungs. So all the blood that's coming to the left side of the heart is coming from the lungs. And when my heart doesn't pump effectively, stuff backflows. So it's backflowing to the lungs. So this person is going to have respiratory symptoms, dyspnea, shortness of breath, pulmonary congestion, pulmonary edema. So fast breathing rate, tachypnea, wheezes, maybe crackles, chronic cough, cyanotic. They're going to probably be a sufferer of orthopnea, so they can't lay flat and sleep or anything like that. General fatigue, cyanosis, orthopnea, cough, respiratory symptoms. You're thinking left-sided heart failure. Right-sided heart failure is also called cor pulmonale, just because right-sided typically happens because someone has lung disease that causes turbulent or sluggish blood flow to the lungs. So the right side of the heart is trying to pump to the lungs. So if there's something like kind of in the preload or afterload sense, resistance in the lungs, that typically causes it. But what the symptoms are is, again, plumbing. Symptoms, manifestations, think plumbing. Where does the fluid go? It backs up into the whole vascular system. So it's coming from the vena cava, from the venous system. The whole venous system gets backed up. And if that happens, you're going to have fluid overload. So right side heart failure patients tend to suffer from severe dependent edema, weight gain from the fluid overload. They're going to have swelling around their stomach. It's the line of the stomach. That's called fluid that increase excess around the peritoneum or the line of the stomach. That's called ascites. They may also have enlarged spleen and liver. A large liver is hepatomegaly. They're going to have an increased venous pressure if you were to do that kind of reading. Distended jugular veins, weight gain, those sort of things. So distended jugular veins, enlarged spleen, liver, ascites, dependent edema. That's all right-sided heart failure. Make sure you know the differences between the manifestations between right and left-sided heart failure. Again, this is kind of showing dependent edema, weak pulse. Again, heart failure patients may have a combination of these. Typically, heart failure does start out as the one side or the other. And then a lot of time, because the heart is working so hard, eventually both sides will fail. And then they'll kind of get a combination of these symptoms. If both sides, right and left ventricles, are failing, we're on severe stages of stage heart failure. We're going to kind of see all these things like pale skin, dyspnea, crackles, orthopnea, blood pressure problems, fluid buildup, edema, ascites, pallor, weak pulse, enlarged spleen, enlarged liver, all those sort of things. Jugular vein distension. You can kind of see the combination of these two, just complete fluid overload if the heart is totally failing. And so this talks about the pathophysiology. It's kind of nice, but basically what this is talking about, to keep in mind with heart failure, again, think plumbing. But one of the body systems that's always needs fluid and blood flow is the kidneys. And the kidneys tend to detect this decrease in cardiac output and try to reverse it by trying to raise blood pressure. So the kidneys here will reabsorb water and sodium and try to increase the fluid volume, but the heart just can't do it. It doesn't matter. It has more afterload and more preload now, but it doesn't matter because the heart can't do anything with it. And so fluid just tends to increase. It's the body just trying to help itself, the kidneys are anyway, by trying to increase cardiac output. But over time, all it really does is just increase fluid and send someone into fluid overload. That's a really normal pathology path or pathophysiology path. So diagnosis for heart failure is definitely echocardiogram is a gold standard. We can do a chest x-ray. That'll show us that the heart's enlarged. Labs, one I mentioned before, is BNP. B as in boy, BNP. Natriuretic peptide, BNP elevated, shows great elevation of fluid and significant heart failure. And then those signs and symptoms we talked about. Objectives for managing heart failure is all about improving kind of functional So there are meds that help with cardiac contractility and that sort of stuff, but we have to kind of do some of the CAD management. We need to do probably diuretics along with other blood pressure controlling medications and cardiac vasodilator medications. But we really are looking for decreasing their fluid volume, managing their diet. This may be a fluid restriction as well, part of their diet, oxygen if needed, if we're talking about respiratory symptoms, management of activity, that sort of stuff. Home management, we want to promote activity and tolerance. That's the main problem with heart failure, is just general activity and tolerance. We want to promote fluid volume management, so restricting how much fluid they take in a day. Also monitoring weight gain from fluid. So one of the most kind of need to know from that is at home management for patients is they're going to monitor daily weights. That's going to be the best way to clarify their fluid volume status. Fluid restrictions, psychosocial anxiety, powerlessness, my heart's failing, and just general health management. Again, medication wise, blood pressure medications, ARBs, ACE inhibitors, diuretics for sure. Digoxin is a medication that basically treats heart contractility. Dopamine, beta blockers, anticoagulants, antiplatelets, because the sluggish blood flow is going to make them more at risk for blood clots. Interesting device. This would be neat to know to reference this, but the interesting device that can kind of bridge the gap for a patient, because unfortunately, once the heart starts to fail, there are scenarios where reversal can happen if it's an acute heart failure based on a secondary condition. But if it's a primary condition that's progressed, especially if it's a heart attack with scar tissue, there's no way to really get that back. So heart failure, unfortunately, there is no cure. The only thing we can do is replace the heart. So heart transplant. And they may not be a candidate age-wise, history of alcoholism or drug abuse, any of that sort of stuff is going to knock them off being a candidate for a transplant or put them lower on the list. So we can do an assisted device called an LVAD. An LVAD is a basically left ventricular assisted device, LVAD. An LVAD is basically trying to bridge the gap between the time of heart failure and transplant. It kind of helps the heart pump basically. Through a battery powered unit that's portable, that's basically trying to do the left ventricular pumping for them and keep blood flow up. This is temporary. This tries to bridge that gap between complete heart failure and heart transplant. But so general complications that bridge this. The pulmonary edema is a big one. Fluid in the lungs is going to equal breathing issues and potentially cardiopulmonary arrest. Arrhythmias are problem. Cardiogenic shock. Cardiogenic shock is basically fluid volume not getting where it needs to be. So organs start to shut down, like kidneys start to shut down because they're not getting the blood volume they need. Liver starts to shut down. And that turns us into a shock. Fluid buildup around the heart, that's a pericardial infusion that could lead to cardiac tamponade. Cardiac tamponade is the name for whenever that effusion, or if it's blood fluid that builds up in the pericardium, is too much that it affects how well the heart can pump. That can lead to cardiopulmonary arrest. Cachexia is a huge muscle metabolic wasting syndrome that happens in heart failure and in cancer, where it just wastes away a lot of our nutrients in our cells and our muscles and general weakness. And then obviously cardiac arrest as the heart starts to fail more. Pulmonary edema is always good to reference. You're going to see this more again with the patients that predominantly have left-sided heart failure. Their symptoms are typically much more lung-related. But again, you can see this with anybody with heart failure because you need to know the difference between left and right heart failure. But as the disease progresses, both ventricles start to fail equally. So sometimes they talk about this being flash pulmonary edema. If it happens real fast, it's a sudden accumulation of fluid in the spaces of the alveoli in the lungs. Again, much more prone in left-sided heart failure, but the fluid in the alveoli mixes with the air, the gases, especially the kind of heme molecule, and it makes this pink tinged, frothy sputum, frothy because of the gases. So frothy being bubbly, soapy looking, pink, frothy sputum is associated with pulmonary edema. And then other stuff is the restlessness, probably sudden breathlessness, feeling of sudden suffocation, tachypnea, hypoxia, almost drowning in the secretions. And they're going to have really, really coarse crackles, very wet, adventitious breath sounds. And nursing wise, it's maintaining airway and oxygenation and diuretics. So depending on their stage, inserting Foley catheter and doing diuretics, or making them not have to do a lot of exercise to go pee. For a man, a urinal; for a woman, maybe a bedside commode. And it's going to be oxygen management, airway management. Arrhythmias can develop from heart failure, basically because of the changes to the myocardium. The conduction system can get a little whack. So we could have the VFib, VTAC, atrial fibrillation, death. Cardiogenic shock is basically when the cardiac output is just so low and inability of the heart to pump effectively. So normal blood volume is just decreased. And this is where you get multi-organ system failure, where the kidneys start to fail and the liver, organs that are designed to have a lot of blood flow, start to fail. Blood clots are always a risk with heart failure just because of the sluggish flow of blood. And so pulmonary embolism development. A thrombus forms somewhere, blood clot somewhere else, and makes its way to the lungs. That's a PE. The cardiac effusion, tamponade, accumulation of that fluid. The need to know here is, again, normally we only have like 20 milliliters in that pericardial sac, that small space between the two layers of the pericardium. And with this, we could look at liters of fluid developing. So you're getting kind of see jugular vein distension, probably fluid shifting out of the vasculature. That's not what you want. You'll see like hypotension, feeling like pressure in their chest, tachycardia or tachypnea, dyspnea, shortness of breath, chest pain. We can do a pericardiocentesis, kind of puncture the heart, remove the fluid, and hopefully regain some functionality. And then this is cachexia. Cachexia is, again, like a huge amount of weight loss, anorexia, just skeletal muscle wasting. You see this in cancer patients. You see this in heart failure patients. And then, unfortunately, eventually, if we can't get a heart transplant, eventually it's possible for cardiac arrest. So remember, with cardiac arrest, if the patient's not responding to you, you check a carotid pulse. The longest you should check for a pulse is 10 seconds. If you got nothing in 10 seconds, you call a code, activate emergency response system, whatever, begin CPR. So again, we don't have consciousness, we're not responding, no pulse, and BP loss, and we're just doing compressions until we can get it. We got a PEA, pulseless electrical activity, or we got a systole, we can't shock, but if you're around somewhere, you can place the pads and kind of go through the motions that way. So that's all the stuff with heart failure, and also included is cardiogenic shock and cardiac arrest to discuss about. But remember, with your CPR stuff for cardiac arrest, and you want to get a depth of about 2 inches on this chest, 100 to 120 compressions a minute. Get the AED if you're in an outsource environment. There's an AED around, get that as soon as you can so you can get an idea of the rhythm, that sort of stuff. And yeah, that wraps up 25 and the heart failure chapter, along with cardiogenic shock and cardiac arrest. So we're moving on to chapter 26 and 27.